So in order for the respiratory system to work, there's 4 distinct things that need to happen. One is pulmonary ventilation. We have to move air into the lungs and then back out. So that's the mechanics of breathing. The second thing we have to do is external respiration, which is getting the oxygen out of the air that's in the lungs and into the blood, and the carbon dioxide that's in the blood out into the air, ready to get rid of it, exhale. Then we have to transport those gases to the tissues, and then we have to do internal respiration, where we exchange the gases at the tissue level. So we'll start with the mechanics of breathing, with pulmonary ventilation. And really, it's breathing in and then breathing out. And how does this happen? We call breathing in inspiration. We call breathing out expiration. So air will flow in down pressure gradients. Where there's an area of high pressure and an area of low pressure, the air will move from the high to the low. It's as simple as that. So we have to look at some of the pressures and define some of these things. So the pressure all around us in the ambient air, in the environment, is called atmospheric pressure. Now this is going to vary slightly, there will be days with high pressure and days with low pressure. It's going to vary with altitude. It's going to vary with a bunch of things. But we'll say at sea level, on average, it's about 760 millimeters of mercury. And for our purposes, and it really doesn't matter because everything is relative, but for our purposes, that's the numbers that we'll use to illustrate this. So that's the baseline. That's the thing that we have no control over. So all the rest of the pressures that we're going to talk about are in relation to atmospheric pressure. Now, a negative pressure is any pressure less than atmospheric pressure. A positive pressure is greater than atmospheric pressure. And if it's the same as atmospheric pressure, then there's no pressure, so it doesn't cause air to flow. So if we have a negative pressure in the lungs, so it's less than atmospheric pressure, air will enter the lungs. If we have a positive respiratory pressure in the lungs, greater than atmospheric, air will leave, and there will be no air moving if it's equal. Now, because we don't really significantly open our respiratory passages and close them, they will equalize to atmospheric pressure all the time. So we'll have a negative pressure temporarily, it will equalize to 0 to atmospheric, and then we'll end up with a positive pressure, and that's how we breathe in and we breathe out. But it will always equalize to the atmospheric pressure because it's an open tube. So we'll call the pressure that's within the alveoli, the intraalveolar pressure, or the intrapulmonary pressure, and that's capital P, P-U-L, pulmonary. So that's the pressure in the lungs. So air will move depending on whether that is greater or lesser than atmospheric pressure. But there's another pressure we have to be concerned about, and that's the pressure in the pleural space, in the pleural cavity. And that's the intrapleural pressure. Now, that's going to fluctuate with breathing as well. But it's always, for a bunch of reasons, a negative pressure. It's always less than the pulmonary pressure, and it's always less than the atmospheric pressure in a healthy person. If it equals atmospheric pressure, then we end up with lung collapse and atelectasis. So what's going to cause this intrapleural pressure being a little bit lower than intrapulmonary pressure is a bunch of factors. The lungs are always trying to get smaller. They are made of elastic tissue, and so they will get smaller just because of that elasticity. Plus, there is surface tension. So the inside of the alveola is wet, and that liquid, that water, has a surface tension. Water molecules are attracted to one another, and so by pulling, this tissue is so thin and so delicate that that force is significant enough to make the lungs want to get smaller. So these two things, it's like a balloon. When you blow air into it, you are raising it above atmospheric pressure, the balloon gets bigger, but as soon as you open it to equalize the atmospheric pressure, the balloon recoils, it gets smaller. So that's going to actually be pulling the visceral layer of the pleura away from the parietal layer of the pleura and making the space, the pleural space, bigger. So this inward recoil of the lungs and the visceral pleura make that pleural space bigger, and when the space gets bigger, the pressure in that space goes down. There's also an elasticity to the chest wall, and the chest wall pulls the thorax outward, which is also making that pleural space bigger. And so those forces together tend to make the intrapleural pressure negative. So if the intrapleural pressure and the intrapulmonary pressure are the same, then the elastic recoil will cause the lungs to collapse. So we call the difference the transpulmonary pressure, and that always keeps the lungs inflated and basically pushed to the walls of the thorax. At rest, that transpulmonary pressure is normally about -4 millimeters of mercury. So this chart looks at it. So there is 760, so this is equalized to atmospheric pressure. The intrapleural pressure is 756. And so the transpulmonary pressure is about 4. So what this means is if you take a deep breath, you will raise the thoracic wall, make the intrapleural space bigger, which will lower that pressure below the transpulmonary pressure, below 4, or greater than 4, I guess, greater than -4. And then the lungs will chase that to try and equalize that to 4. And so the lungs will get bigger. And as the lungs get bigger, the pressure inside the lungs, so the intrapulmonary pressure, will drop because the lung has gotten bigger. And when it drops below atmospheric pressure, air will rush in to equalize that. And it'll reach equilibrium again. So that's really the basis of inspiration. If the pressure in the lungs goes down, the intrapulmonary pressure can go down because of plugged bronchioles. Because what will happen is you will be absorbing the gases from the trapped alveolar air, and pressure will decrease. When the pressure decreases by 4, then that part of the lung will collapse. Or if the pleural space gets to atmospheric pressure because of a wound that allows air, it's called pneumothorax, you will get atelectasis. You will get the lungs collapsing. So these volume changes cause pressure changes. The pressure changes cause gas to flow and then equalize the pressure. So that's really the bottom line. So this is called Boyle's law, and it's the relationship between the pressure and the volume of gas. And I mean, this British scientist in the Victorian era got to have his name on a law for stating the obvious. What he says is that if you squeeze something, the pressure goes up, and if you relax on it, the pressure goes down. That's kind of so what he's saying is pressure varies inversely with volume. As volume goes down, pressure goes up. As volume goes up, pressure goes down. And that there's an equilibrium in that. Every kid that's ever stepped on a ketchup pack knows that the pressure will go up until it pops. This is how you pop pimples. I find it interesting that it's Boyle's law is popping pimples. Squeeze it, the pressure goes up, etc. So when we breathe in, it takes muscular energy. It's an active process. If I was to ask you all, as you're listening to this, to take a deep breath, you actively do it. You think about it. You contract a certain group of muscles. You contract the diaphragm, which flattens it out, makes the thorax bigger, and pressure will go down because the volume goes up. You will raise your ribs up, which will increase the volume, so therefore decrease the pressure, and air will flow in. But this is a conscious, active thing that we use skeletal muscle for. So we flatten the diaphragm, raise the thoracic cavity. We use the intercostal muscles. I'm not going to ask you to know the names of the muscles or anything. Now, expiration in a normal, quiet breathing is a passive thing. So take that deep breath. Now let it out. All you did was stop contracting the muscles of inspiration. You just let them relax. And so it's a passive process. The ribs will drop, so the thoracic cavity volume decreases. The diaphragm will push up because as it relaxes, it domes up and makes the thoracic cavity smaller. As the thoracic cavity volume goes down, the pressure goes up and the air leaves until it equalizes to atmospheric pressure. Now, if you are blowing out birthday candles or blowing up a balloon or something, what you end up doing is tightening the abdominal muscles to make the abdominal cavity get smaller, increase the pressure in that, which pushes the diaphragm up further and makes the thoracic cavity smaller forcibly, and you can increase the pressure, and you can have an active exhalation, but normally it's just relax and you exhale. So that's the chart that's looking at that. So the transpulmonary pressure will vary a little bit. in that. So the ribs lift, the pleural space gets bigger, the pressure drops in the pleural space, which increases the transpulmonary pressure, which then makes the lungs chase after that, which then makes the lungs bigger, which then decreases the intrapulmonary pressure, which then, when it's below atmospheric pressure, air goes in. So what's opposing this? What's going to influence this happening? There's really three factors. One is airway resistance. So getting air through the bronchi and the bronchioles. If they're plugged with mucus or scar tissue or anything like that, then the airway resistance is going to go up, which means ventilation is going to go down. Another thing is the alveolar surface tension. So if the lungs are very damp and there's not enough surfactant, then the surface tension will make it very difficult for the lungs to expand. It takes more force to expand, so you'll have less expansion and it'll be more difficult to take a breath in. And then there's this idea of lung compliance. Compliance means how easy is it to do something. If people are compliant, it's easy to get them to do things. So compliance is to comply, to make it easy. So if lung compliance is high, then it's easy to breathe. And if lung compliance decreases, it's more difficult to breathe. So the airway resistance is really about this friction. It's about passing air through tubes. Flow equals delta P over R. And you'll notice that it's the same thing that we used in cardiovascular, that blood flow equals the difference in blood pressure from one area to the other over the resistance of the blood vessel. This is the same thing. The airflow depends on the pressure difference over the resistance. So resistance is inversely proportional to flow. So if resistance goes up, flow goes down. If you want flow to be the same, then the delta P, the difference in pressure, has to go up to compensate for it. For those of you who have ever done any electricity or any in physics, it's the same as Ohm's law. Current equals voltage over resistance. Current is really the flow of electrons. Voltage is the delta P, the pressure change, and resistance is resistance in the wire. And so yeah, it's flow is directly with pressure changes, and it's inversely to resistance. Usually resistance is insignificant because the large airway diameters in the first part of the conducting zone pass air fairly easily, but you would think that the resistance would go up as the bronchioles get smaller and smaller and smaller. The problem is it's the same as capillaries. There are millions of bronchioles, and so their total cross-sectional area is actually greater than the trachea. So if you think of it, the trachea, say, has a cross-section, so say is a diameter of about, about 5 centimeters, and the two primary bronchi each have 3 centimeters. Well, now that's 6, which is bigger than 5. And then the secondary bronchi have 2 each, but there's 3 on the one side, so now there's 6, and 4, which is still bigger than, and so it just keeps on, the total cross-sectional area just keeps on getting bigger and bigger and bigger, so resistance goes down and down and down. So there's virtually no resistance in the respiratory, in the terminal bronchioles and the respiratory bronchioles, where you enter into the alveoli. So it's kind of in the medium-sized bronchi that the resistance peaks, and these have muscular walls, and so this is where we control ventilation and perfusion. This is the place where people with asthma have the increased resistance because of bronchial constriction. If the resistance goes up, then you need a greater delta P, so it becomes more strenuous to breathe. So somebody with COPD, chronic obstructive pulmonary disease, will have trouble because their resistance is chronically high. They will have to expend more effort to move the same amount of air. They'll need a delta P. And that's why you see people with COPD that are laboring to breathe. And it's also why you see them get tired very easily, because they're using all their ATP, all their muscular energy, just to breathe. It's a very tiring disease. Asthma is a transient effect of that. We can bronchodilate using drugs and things, but to reduce the resistance, but that has its issues as well. Okay, the surface tension of the water that's in the alveoli, because water molecules are attracted to each other, they are performing a force on this delicate tissue. And so to expand the lungs, you actually have to pull the water molecules apart from one another, and there's an attraction where they want to get together. So you have to overcome that force. Now, it seems insignificant until you start to look at the amount of surface area, and then it builds up. So yeah, the surface tension is an important thing. So the type 2 cells in the alveoli make a detergent type of secretion called surfactant. And the surfactant gets between the water molecules and basically breaks the attraction of the water molecules, so it diminishes the surface tension and makes it easier for the lungs to expand. When babies are born prematurely, surfactant is one of the very last things that the baby will make. The type 2 cells are the very last thing to become developed before birth, because the baby has no need, they don't breathe in the womb, so it's the last thing that happens. And if a baby is born before the type 2 cells are making surfactant, it's very difficult for the baby to breathe. And that's why we put them in an incubator, and the gases that we pump in, the moisture in the air that we pump in, has surfactant added to it, so they actually breathe the surfactant, and the moisture that's in there has the surface tension broken, and it makes it easier for them to breathe. It's called infant respiratory distress syndrome, but again, we're not doing, this is not a pathology course. It's just talking about that for context. Now, a story that I can tell you, a patient of mine, a guy who actually is a prof here at Georgian, He was a competitive swimmer all his life, and I know him quite well. And so he spent day after day, hour after hour in the pool, breathing the air just over the surface of the water. And they were chlorinated pools. So he breathed a lot of chlorine in his day. And chlorine is poisonous to the type 2 cells, so he started making less and less and less surfactant. And then what started to happen was the surface tension got really high for him, and he had spontaneous lung collapses. He's had quite a few of them over his life. So what they've ended up doing is pouring an irritant into his pleural space and having scar tissue hold his lungs open because he doesn't produce enough surfactant. Okay, lung compliance is the third item in this. So lung compliance is normally very high because lung tissue is very distensible, and the alveolar surface tension is normally broken by the surfactant. I think to demonstrate this, you know how when you get new balloons, you're going to have blow up some balloons for a party, that you go to blow into the balloon and it's very difficult to inflate the balloon. So you stretch it a little bit and then you try blowing again, and there's resistance, and then all of a sudden it becomes compliant. So by stretching the balloon, you're breaking some of the adhesions in the rubber and making it more compliant. That's kind of the point. So lung compliance will be diminished by scarring in the lungs, so non-elastic tissue, fibrosis of the lungs is a big deal. Reduced production of surfactant, like my buddy, or you can have decreased flexibility of the thoracic cage, so broken ribs will do it. Scoliosis, so structural changes, will mean that it's harder to inflate the lungs. You can't lift the ribs, and that will decrease lung compliance and make it more difficult to ventilate. So any of these deformities. A good friend of mine has a disease called ankylosing spondylitis, and it's an arthritic condition that will affect the joints of the spine and where the ribs meet the spine. And so that's a problem. Sometimes people end up with paralysis from like a broken neck or a stroke or something like that, and some of the intercostal muscles, so that will decrease lung compliance. So the bottom line is ventilation happens because of pressure changes. To breathe in, we want to make the lungs bigger to reduce the pressure below atmospheric pressure. Air will rush into the lungs and fill the lungs to equalize the atmospheric pressure. If we make the lungs smaller by making the thorax smaller, we increase the pressure, according to Boyle's law, and it pushes air out until it equalizes to atmospheric pressure again. We have to overcome resistance because the difference in pressure over the resistance gives us the flow. So we have to minimize the resistance so that we don't have to maximize the pressure difference. Resistance is the airway resistance, the surface tension of the liquid in the alveoli, and the compliance of the lungs, the elasticity and the ability for the lungs to expand.